Everyone, good morning. Welcome to the Managing the Risks of COVID-19 for Families and Young Children. Now, as most of you know, Case Western Reserve has done a really good job protecting our community from COVID-19. Having almost universal vaccination combined with indoor masking, the university is really among some of the safest places in the region when it comes to COVID-19. After having an impressive 0.68% positivity rate during the first week of classes in August, we have actually now improved. For the week that ended October 18th, our positivity rate stands at just 0.08%. And only 10 positive cases were reported among more than 16,000 students, faculty, and staff. But while we've diligently protected the members of our campus community, we do know that there are concerns remaining among our families, and that's our mothers and our fathers and caretakers who are responsible for children too young to receive the COVID-19 vaccine, and that includes myself. So that's why we created this program. We know that you have many questions, we know that you have concerns, and we know that no matter what, you want what's best for your children. Like many of you, I know the struggles of 4:30 meetings that barely leave enough time to get home for the basketball games, or conferences that overlap with black belt ceremonies. And I know that managing the risks of COVID-19 in a family with young kids can be tricky. So today you're going to hear from experts, including the School of Medicine's Dean, Stan Gerson, infectious disease expert, Bob Salata, and adolescent psychiatrist, Ruth Gerson. They're all going to provide you with the latest science regarding vaccines, boosters, variants, and more. And they're going to talk about transmission to children and approaches to managing the psychological needs of kids during COVID. We also have a handful of members of our staff, and that includes Executive Director of University Health and Counseling Services, Sarah Lee, and General Counsel Peter Poulos, who are going to be talking about campus safety measures. And of course, later on, we're going to be taking your questions. So let's get started. I am going to start briefly by introducing the Dean of the School of Medicine, who will introduce our remaining panelists. I think everyone here probably knows Stan. Stan is the Dean and Senior Vice President for Medical Affairs in the Case Western Reserve University School of Medicine. He is the Acting Director of the Case Comprehensive Cancer Center and the National Center for Regenerative Medicine. As you can all imagine, he has been an indispensable member of this team and a wealth of knowledge as we've navigated COVID-19. Stan, over to you. And you are on mute, Stan.
Muted. So thank you and good morning. I think this is actually a very important conversation. We've got a short period of time, so I'll do a brief introduction to let our experts give us a background and perspective on this ever-changing environment. And as we're hearing overnight, booster vaccines are coming along, vaccinations for 5 to 12-year-olds are coming along. So with us are two experts who I'll just briefly introduce. Dr. Robert Salata, who's been leading the effort at university hospitals as chair of the Department of Medicine and longstanding member, former chief of the Division of Infectious Diseases at university hospitals and at Case Western Reserve University, an eminent expert in the issues related to vaccines, vaccine management, and risk assessments, who keeps an incredible worldly view of this complex space. And I'm also delighted, because of the topic around children and managing children risks, et cetera, to bring with us Ruth Gerson, who happens to be my daughter, who is the Senior Vice President for Mental Health Services at the New York Foundling, where she is an adolescent psychiatrist, oversees psychiatric and mental health services for young and foster care, and also is a clinical associate professor in the Department of Child and Adolescent Psychiatry at NYU School of Medicine, received her training at Bellevue in adolescent psychiatry, and before that at Columbia University, where she received her MD degree. She has, in fact, published a couple of books, which you can look on her website about. So she has really focused on these issues that are very complex to all of us. So I'll turn it over to Bob and Ruth.
Good morning, and it's a pleasure to be here today. What we thought we would do is kind of set the stage with respect to some of the information that we're currently dealing with. And then we'll let this flow into the questions as we proceed. First of all, we're looking at US data in terms of COVID cases. And the good news, if you look below, is that for the fourth consecutive week, we have seen a decrease in the total number of cases, tests performed, those hospitalized, and associated deaths. Usually the hospitalized numbers and deaths lag behind the cases. Next, if you hit the next thing, it's important to realize, and I just finished the clinical service last evening, and it is an inpatient infectious disease service where we had hospitalized patients with COVID. But both Centers for Disease Control and the Kaiser Family Foundation have shown across the country that unvaccinated individuals account for about 95% of those that are currently hospitalized. And the few that have been vaccinated either have significant medical conditions and or are immunocompromised and likely had a very poor response to the vaccine. Next slide, please. And if you look at hotspots in the United States, where purple is the worst, we have moved away from the Southeast, where this was particularly a problem, and have moved more to the Northwest in terms of cases, and then also in the Midwest, excuse me, in places like Minnesota, et cetera, Michigan, but less so in Ohio. And you could directly correlate on this slide the unvaccinated individuals with regard to their risk for developing COVID and thereafter severe disease. It's been shown recently in CDC data that folks who are unvaccinated who develop COVID have an 11-fold increase in serious disease and death. Next slide, please. But, you know, we're dealing with a global phenomena, and it is unequally distributed across the board. And when you think about the global occurrence of COVID, it is the case that some of the real hotspots in the world, Russia is one of them right now, but sub-Saharan Africa and other developing areas of the world have a high burden and have very little to offer in terms of vaccination. I work in Uganda and have done so for over 30 years. And there only about 1% of their population has even been offered vaccination to date. The importance of this is that with the high burden of infection globally still at this point, we are faced with the potential for the virus to further change or mutate into these variants. And we'll talk about that in a little bit. But worldwide, the predominant circulating virus is the Delta virus. And in the United States, it accounts for 95% of all cases. Locally, it's 98 to 100% of all the new cases of COVID that we see. Next slide, please. How's Ohio doing? You can see we're on the downward trend. And although we have seen substantial decreases in cases and hospitalized patients, we're lagging behind in terms of deaths. And some of the hottest spots are shown in the deep purple color in the state. As we'll review, Ohio has not done a great job in terms of vaccinating their populations as opposed to the rest of the United States. So that's what we're dealing with. And it's to the credit of Case Western Reserve University in keeping the numbers very low. Next slide, please. Again, if you look at the risks based upon unvaccinated individuals. It's pretty much throughout the state. Next slide, please. Very importantly, if you look at age groups, and we'll start to discuss this a bit in terms of children, et cetera, you could see on this panel that in all age groups except those that are 60 years of age through the age of 79, that the rates over time have decreased, and that's a good thing. You can see this graphically on this side. With regard to children, September was the worst month in the entire pandemic to date in terms of numbers of cases in those that are less than 18 years of age. That accounted for about 1.1 million of cases reported. Though children overall are less likely to have severe complications and die, the numbers of children that died in the September time period was 41. We don't like to see that at all in children. And then there are two other phenomena that we're seeing in those children as well. One called the multi-organ inflammatory syndrome, MISC, and this seems to be an immunologic phenomena that occurs with prior COVID infection in these children. There have been reported over 500,000 cases in the United States, and it does account for some of the children that end up being hospitalized in the ICU, et cetera. And the other thing that's happening is that many of these children that have had COVID, probably up to a third, have had longstanding symptoms. This represents the long COVID syndrome, and especially since fatigue and problems with brain fog, et cetera, is an issue in these children. It is impacting on their school performance, among other things. We have set up a special clinic at university hospitals to not only deal with the adults with long COVID, but also children now, because that's an increasing number. Next slide, please. So at university hospitals, we still are seeing our share of cases, with about 15 to 20% of them residing in our ICUs. But that's actually diminishing if you look at the curves below. And we're going to continue to follow this out. There seems, again, nationally and globally to be some diminished numbers of cases of COVID, as well as the predominant circulating virus, which is Delta. Next slide. And Delta, by the way, has really been a game changer in terms of affecting younger age groups, et cetera. In the cases that I just was dealing with in the hospital, all of them were unvaccinated, and all of them were less than the age of 50. And that's important to realize. In terms of vaccination, because this is always a race between adequate vaccination versus the emergence of these variants. If you look in the United States, the good news is in our most vulnerable individuals, generally those that are 65 years of age or older, we're doing a better job in terms of vaccinating, at least with one dose, and fully vaccinated constitutes about 85%. And then if you really look at the eligible folks, individuals 12 and up right now, we're doing a better job in terms of getting them vaccinated. Next slide, please. Ohio, though, lags behind. So if you remember those numbers we just looked at, this is about 10% decrease in the numbers of vaccinated individuals at all age groups. Next slide, please. And the United States is probably in the middle of the pack, around 15th in terms of getting our population vaccinated. You can look at other countries where they've done a much better job. And I just want to point out that Israel has been one of the places where real life data has informed some of the issues related to boosters and waning immune response, et cetera. And so I think they've led us in that regard as well. Next slide, please. And the other thing we've talked about is getting sufficient people vaccinated. That's around 837,000 doses per day now, whereas we were close to 3.5 million back in April. And we need to increase this again. At the moment, there are more people receiving boosters than the initial doses for vaccination. Next slide, please. And then the other thing I would just want to point out, this is published in the New England Journal of Medicine. It looks at healthcare workers from the University of California, San Diego. But it is the case that these individuals, are receiving vaccine, but there's some waning of the immune response, particularly over time. Next slide, please. And that is demonstrated here that 5 months, 6 months after vaccination, the protective level, both of Pfizer, less with this number compared to Moderna, which is a little bit higher, it goes down, and that served as one basis of data for recommending the boosters. Next slide. And the other thing to realize is that, again, from this study in the New England Journal of Medicine, there was some waning of immune response, particularly after 6 months or so. Next slide. And very importantly, from this Israeli study, you were able to boost up that immune response in terms of antibody response after the boosters were given. And that served as another point of evidence for recommending the boosters. Next slide. So next slide, if we can go on. Their first boosters were recommended for so-called immune compromised individuals. These are the folks that should have in August been receiving this through an emergency use authorization, but now it's been broadened. Next slide. And the Pfizer booster, which came into play first, these are the populations that should be boosted in that regard at a point of 6 months after their second dose. And just recently, as of yesterday, the Advisory Committee on Immunization Practices to the CDC and the CDC director authorized boosters for the Moderna vaccine as well as J&J. In addition, for the first time, they authorized the use of mixing and matching vaccines. And in fact, for the J&J vaccine, which was given, as you remember, as a single dose, the use of the mRNA vaccines as a boost was associated with significant improvement in immune response. In fact, with Moderna, it was 56-fold higher. It was 36-fold higher in those that received the Pfizer vaccine. Next slide, please. And then this was the Israeli data showing there was a boost clearly in terms of not only immune response when the boosters were given, they were doing it at the age of 60 and greater, but also they were protected against reinfection with this boost phenomena. There is also some consideration of lowering the age of providing boosters to 40, in part based upon this data, as well as that from Denmark and other places. And I'm going to, Lisa, stop here and see if my colleague, new colleague that I've met, Dr. Gerson, the younger Gerson, has any further comments, please.
Sure. Lisa, do you have the slides for me? Do you want to pull those up? Thank you. I'll just start by saying that I, as Dr. Vincent mentioned this for himself, but I am also the parent of young children. And so this is also a topic that is very near and dear to my heart. These are, I can't tell if you guys can see me, but these are my kiddos on my mug here. They're 4 and 6. So this is absolutely something that I think about a lot. Lisa, can you jump to the next slide? Or do I have control over it? Okay, thank you. So I'm not going to do any fear mongering, but just telling you guys what you already know, which is that we worry about kids' mental health because there's been plenty of reports that show that anxiety and depression have been rising in youth for a long time, but especially during the pandemic. We know that there are rising suicide rates in young people, including younger and younger kids, and a particular increase among kids of color. And just subjectively, I think we feel stressed, our kids feel stressed, we know the teachers are stressed. So thinking through, how do we support our kids through this time? Next slide. Thank you. One piece I'll say, and my understanding is that this is largely folks who, like me, have little kids, not necessarily teenagers, though. If people have questions about teenagers, I'm very happy to talk about that. But an important thing to keep in mind is that little kids, preschoolers, school-age kids who are anxious or who are depressed don't always look like adults who are anxious or depressed. We tend to see much more kids being irritable, an increase in tantrums, developmental regression. So kids who previously were able to sleep independently without a parent now start to want a parent. Kids who were perfectly fine with separation and had no problems with separation anxiety go back to that sort of more preschool age stage of having a lot of anxiety around separation, or a lot of anxiety around having a caregiver come as opposed to a parent, or around going to school. Sometimes we even see toileting regression. So kids who are toilet trained suddenly having more accidents, and a lot more physical complaints, stomach aches, headaches, not feeling good, that kind of thing. So just something to keep in mind when we're wondering, how is our kid doing? And if people have teenagers that they want to talk about, I'm happy to talk about how you distinguish adolescent anxiety and depression from the normal just storms of adolescence. But I won't go into that because I think this is a largely younger kid group. So go on to the next slide for me. So a couple tips on how to support kids' mental health during COVID. So the very first thing I would say is to prioritize connection. We have so much that we're dealing with right now. I see this with me and my partner. We get stuck in the logistics and the planning and the packing the backpacks, and then now it's time to get ready for bed, or now it's time to get ready for school. And it's hard to find the time to really connect one-on-one with our kids. So really prioritizing that connection, because when we're stressed, that connection is what we fall back on. That connection is what our kids fall back on. Prioritizing time to connect one-on-one for older kids, trying to encourage them to make real life connections with peers or with teachers. We know that kids who feel connected at home and connected to peers or to staff at school are at less risk for mental health problems, and particularly for suicide. So encouraging kids, even if they're anxious about, what if I catch COVID on this play date or something like that, finding ways to encourage them to have connections with others, to have connections with us. And also for us as parents to make sure that we have open lines of communication with teachers, and that connection is there so that we can hear how our kids are doing. Getting enough sleep is another big one. It's self-explanatory, but kids need way more sleep than we typically think that they do. And little kids don't seem tired when they aren't getting enough sleep. They just get crazy and weepy. And so making sure that kids are getting enough sleep. If they're catching up on sleep on the weekends, if kids are sleeping more on the weekends, that means they're not getting enough sleep during the week. And physical activity too. And I know, I live in New York where it gets cold as it does in Cleveland. This is so hard in the winter, but making sure that we give them ample opportunities for physical activity, even as it gets cold, even as it gets harder to feel safe doing things indoors, layer up and try to get them outside running around, even though it's hard to motivate them sometimes. And then a couple sort of more psychological pieces. One is around being curious. We want to model for kids how we can be curious both about our own experiences internally and our own concerns, and teach kids to be curious about information that they hear. So, if a kid says, I'm feeling anxious about this, trying to help them think about, oh, that's really interesting. I wonder, what is it about that situation that's making you feel that way? Is it this? Is it that? We're teaching them to not be controlled by their feelings, not to be controlled by their reactions, but to be able to look at them in a welcoming but curious way. And similarly about the messages and information that they get from peers or that they get online. If friends or someone says something, that's interesting. We can be curious about where that information came from and how we decide if it's true. And that's something that we can do together as a family. We can think about whether or not that's true. And then the next step of that is validating their concerns, but also helping them to evaluate their concerns. This can be for kids' concerns or for our concerns, right? So rather than jumping to reassurance or solving the problem right away, which is, what we want to do for kids, right? We want to help them not feel scared. We want to help them. We want to reassure them right away. No, don't worry, honey, it's going to be fine. But that actually makes it harder for them to feel like we're taking their concern seriously. So validating their concern, saying, I hear that feels scary, or I really hear that this doesn't feel good to you. And then helping them gently try to evaluate the concern. So let's say a kid is scared about being in the classroom because they're worried about catching COVID. What information can we find about how much risk there is in their actual classroom? What's the school doing to reduce risk? What can we ourselves do to reduce risk? Like, is it about wearing masks? Is it about getting tested? And then how does it feel, knowing that I'm wearing my mask? How does that change how I feel about that worry? Does it make it bigger? Does it make it smaller? We're teaching kids how to evaluate risk, which is something that none of us as humans are very good at doing, while also reassuring them. And I think that skill building is so important, because I think about my kids who are going to be teenagers someday, and they'll really need to know how to evaluate risk and to be able to do that for themselves. So trying to see this as sort of a learning moment where we can teach them that skill and help them build that ability that they can then use for moments when we're not there. And then the last piece is planning and practicing how they're going to cope. So let's say that there is a COVID exposure at school and the kid is home. Who's going to take care of them? What are they going to do? How are we going to keep ourselves safe and make sure that we don't pass it on to anyone else? Or if the kid is worried about going back to a routine that they haven't been doing before, how do we ease them back into it? How do we practice it if there's a change in the routine? I think about this with my kids who were quite small when we started COVID, and teaching them how to wear masks. And we practiced wearing masks just for like a couple minutes here and there, and practice wearing masks at different times and doing it in different ways. We practiced hand sanitizer because my youngest child was totally phobic about hand sanitizer, which was a little ridiculous. So giving them that space to practice the routine and really checking in with them, if we do this, how does that feel? If we do that, how does that feel? Making it silly, making it fun, and giving them the chance to realize that they can master this new thing. They can cope with this new thing, even if it's scary. And I think it's also helping us know that they can cope with that, so that we don't have to worry, and that they know that we can help them through it. So with that, I'll open up if people have questions. I think my next slide says questions. If you want to advance the next slide, or we can continue on, depending on how you guys want to structure.
I think I want to thank you, Ruth. You calmed me down, so that I hope everybody else as well. I want to move on to Sarah and Peter, and they were going to give us some logistic issues around the university environment. And perhaps in your comments, I could have you address the couple of the questions that came in before we started that are related to the topic. So Sarah, Peter, you're the tag team. Go ahead, please.
Well, I will just give like a 30-second high overview summary, and then turn it to really who's been at the forefront of not only our strategy, but she's also been on the front lines in our effort to keep our campus community safe. And her team has done a magnificent job really from the start, which is at this point over 18 months. So a big thank you to our medical director, Dr. Sarah Lee, and her entire team. But just at a high level, the overarching framework that we have used for our COVID, what I think of as our rules of the road and framework, has been the campus safety obviously is our first priority and our overall mission, and that whatever framework we utilize has to be flexible to adjust to both changing circumstances of how the virus is impacting our community, and also changing guidance and changing regulations that are applicable. And that's been kind of our approach since day one. And as if anyone's followed our rules of the road over time, they know our rules have changed over time as necessary. But with that, let me turn it to Dr. Lee with her thoughts on both kind of our approach, and then I know there were a few questions that she's the most expert on to answer. Dr. Lee.
Thank you, Peter, and thank you to Dr. Slata and both Dr. Gersons for talking today. I really enjoyed both and have learned a lot. I think what Peter said is both what's excellent about what we do and also what's so challenging. So the university really has been quite flexible and adaptable, but all of that change is really hard. So I think Dr. Gerson would agree, it's hard for children, it's hard for adolescents, and it's hard for us. It's been constant change. I know that the doctors who work with me, the fact that every Monday when we're huddling, I might be announcing something new that we have to do in terms of the COVID guidance. It's hard to keep up, but it's just also hard to get your brain in that framework of stuff changes pretty constantly, and the guidance changes and sometimes is contradicting what we said 2 weeks ago. So that's very, very challenging for people to recognize. I'm going to address some of the questions that had come in previously, one of which was, what's the university doing to support a safe and healthy workplace, given that parents of school-aged children are coming to campus? I think, the most important step, which Provost Vincent talked about, is the requirement that everyone be vaccinated. Every vaccinated person really helps to limit the virus's ability to infect and spread. And we are a highly vaccinated campus. Dr. Salata pointed out that Ohio isn't doing so well, but we are. This is, it's very hard to find an unvaccinated person on our campus. And that really protects people who are on our campus, and therefore protects you when you're going home to your child. We also have an indoor masking policy at the moment to prevent spread while community transmission is high. We have a robust flexible testing program. It includes surveillance, voluntary testing, so anyone who wants one can get one, exposure testing, and symptomatic testing. We have our own contact tracing program, so that we can respond more quickly when we're notified. And then we consult regularly with infectious disease experts, one of whom has graciously joined us today, and public health experts as we monitor the ongoing pandemic locally, nationally, as well as on campus. I've been quite impressed with watching and then taking part in how the university has managed this. Some of the other questions were, someone asked if we could connect parents to rapid tests to avoid sending children to school or adults to work if symptoms were present. So CWRU faculty and staff who have symptoms can call health services to arrange for testing. And this likely includes rapid testing as long as we have supplies. For other adults in the home, you may want to purchase rapid tests at the pharmacy or on Amazon. Just remember, and obviously Dr. Salata is the expert in this, but a positive test in someone with symptoms is correct. That person has COVID in general, but a negative test in somebody with symptoms needs to be followed up with a more sensitive nucleic acid amplification test, what we're usually calling a PCR test. And so, you do probably want to do these, particularly for children, in conjunction with your pediatrician or primary care provider. Another question was, what notification of CDV of the university, of coworkers, and or testing is expected of parents with symptomatic or positive testing children? So first, we know kids get sick and your worry level has only increased with COVID. Your first responsibility is to take care of your child, your family, yourself. If your child has COVID-19 and you are fully vaccinated, you won't need to quarantine. We do ask that you call health services so that we can talk with you about testing. There's new guidance from the CDC for people with ongoing household exposure, and parents with young children definitely qualify. We're going to guide you through when to be tested and help arrange that testing. You're also going to be asked to monitor for symptoms and mask for a period of time. Your coworkers won't need to be notified for contact tracing purposes, but depending on the age of your child, you may need to take time away from work to take care of them. And then we can help you, or you can contact HR. People who aren't vaccinated should really consider getting vaccinated to protect their children. And there's separate guidance for them. If your child has symptoms, at this point, really the recommendation is that anybody with symptoms needs to be tested, but you don't need to necessarily notify us if they test negative for COVID-19.
Thank you. I'm going to have Ruth address a question that came in about the management of a family with young and older children, where one of the children is under 5. And then I'm going to prep Bob just to look in the Q&A, because there are 3 questions related to boosters and vaccination that I'd like you to address right thereafter. Thank you. Ruth.
Sorry, what was the question regarding children? I don't see it in the Q&A.
Sorry, it was one that was sent in. It says, what are your recommendations for best practices for very young children, those that are too young to wear a mask, who are attending daycare and aren't eligible for the 5+ vaccine?
Well, I would say from the mental health perspective, the first thing I would say, and I'm saying this from my own personal experience of having a 4-year-old who's too young to be vaccinated, is to remember that the little kids do seem to be less affected. So I think the first step for me, my own self, has been calming my own anxiety and my own concern as a parent, because I have found that if I get too rigid about, this is so scary, you need to wear your mask every second, it makes it harder for my daughter, and it actually makes me less effective in helping her to be safe and helping her to do the steps that she needs to do to be safe. I think every family has to come up with the right balance for them. I will shortly be in a situation like I think what they're describing, where older kids are able to be vaccinated and younger kids are not. And I think one of the things that can come up with that is the older kids can say, well, but my friends can do this, and my friends get to do that. My friends get to, have indoor dinners with friends, or my friends get to have sleepovers. Why can't I? And I think just for kids that every family is different and every family situation is different, and we have to make decisions that are right for all of us as a family and keep everybody safe. And to give them space to disagree with that and to be mad about it, to be frustrated that they have restrictions that maybe other kids don't have because they do have another kid in the home that can't be vaccinated, or because our family has made different sort of risk benefit calculations than others might. My youngest has a heart condition, and so we probably will make slightly different calculations than others do, even after the big siblings are vaccinated. And just being open with kids about that and helping them in a way that's developmentally appropriate, right? Like not getting into the statistics or things like that, but just helping them think through and then giving them space to disagree. I really like, there's a psychologist named Dr. Becky Kennedy, who talks about saying 2 things are true. 2 things are true. One is that I have to make this decision for our family, and you are allowed to be mad about it, and that's okay. And giving space for both of those things.
Thank you. And Bob, you've got 3 tough questions here. One is, will the full dose of Moderna for a booster cause harm? And then I'll let you carry on with the others. Go ahead.
Yep. So Moderna and J&J were just authorized, including all the way to the CDC director's level for boostering. And it's likely that we'll start seeing this roll out next week. Although over 1 million people have already sought boosters without this authorization in place, but now we're free and clear, so to speak. The Moderna vaccine for boostering is only 1/2 the dose of that was given originally, with 2 points in mind. One is that it was as effective as the 100 microgram dose. And secondly, there appeared to be fewer side effects associated with that. And if you look through the literature very carefully, there is some advantage for Moderna over Pfizer a bit in terms of the long-lasting immune response. The other point is that Pfizer just announced, and we were involved in the study at UH, their results from boostering with 10,000 individuals involved, and that was placebo controlled. And indeed, there was a 96.7% increase to that level of immune response. So that looks good. And they're looking further at T cell responses, which is another form of immunity that probably has not been as emphasized in terms of immune protection. For the young children 5 to 11, Pfizer just announced this morning, released a little bit of data that their safety profile looked very good. And it was no different from that which was seen in adolescents. And it was short-lived in all respects. And their rate of immune protection was 90.7%. So I think parents will have to make this decision about whether they want their children vaccinated in those age groups. Younger children, including to the age of 6 months, are being studied as we speak, and likely there will be deliberation of the data by the FDA in December, with possible approval if this holds up after the first of the year. So that's where we're headed with all age groups, remembering that many of these children have protective antibodies below the age of 6 months, especially if their mothers were vaccinated during pregnancy. That all said, we are looking forward to this. And the other thing is, if one is concerned about side effects to one of the vaccines, before there was a question related to that, I think it will be mitigated by the dose of Moderna utilized, but you also have the option now to mix and match vaccines. This was based upon a large NIH-sponsored study that's still in preprint, but it served as the basis for all the advisory groups to say, if you really wish to switch to a different vaccine, you now have that prerogative, not just solely based upon supply, because there's an abundant supply of all the vaccines in the United States right now, but it would be preference as well, particularly with regard to J&J, which in the original studies was only in North America, only about 60% effective in promoting vigorous or robust immune responses. So that's where we stand. So we have all three available vaccines from the US now available for boostering, and you can mix and match. That was the final decision last evening. Was there another comment, Stan?
So I'm going to let, thank you very much. That was very clear. I'm going to let Sarah tackle two questions related to case, and perhaps have Peter comment on teaching faculty concerned about a booster due to a strong reaction to a prior dose, which you covered briefly, Bob. But Sarah, could you comment on the breakthrough case and the risks that we might have with that currently?
Dean Gerson, is that the dashboard question?
Yes, correct.
So there's a question asking, so the dashboard, the positivity rates are calculated based on the number of surveillance tests. And so we take the number of surveillance tests and then the number of positive cases that we found via surveillance. We also report out the number of total cases, and those are found via a number of mechanisms, including the testing that we do for symptomatic individuals in clinic, as well as self-report. So for the self-report, there's no denominator. So we don't know how many individuals tested and tested negative. So for self-report, that's often the faculty and staff who are calling to tell us that they took a test through, they took a rapid test at home, or they took a test through UH or one of the other institutions, their primary care provider. And so we include those so that we're transparent. But to include that in the positivity rate, then we don't have the full denominator. Most of the time, even when if we were to include that, the positivity rates on campus are still far lower than those in the surrounding community. In terms of breakthrough cases, and here I will definitely defer to the expert who on my Zoom is to the left of me. So please jump in and save me if I'm wrong. But what we're finding with families with young children is they are not, so there are breakthrough cases. The vaccine is very, very good, but it is not perfect. And so these mild infections where people are not getting hospitalized and not getting seriously ill are not unexpected. What we're finding is they are not acquired on campus. They're acquired either in the community or from children who were infected at, in the community or at school. So the risk on our campus continues to be low. When we find cases, we do contact tracing, finding who those people were in contact with, but we also do some case investigation to figure out where that person might have acquired it. So that would be my answer there. Dr. Slada, how'd I do?
You did great, Sarah. If I can just add, nationally, there have been over 10,000 vaccine breakthrough cases reported. But that is in the context of over 150 million folks being vaccinated. So it represents a relatively infrequent phenomena. And very importantly, the other issue is that, as you mentioned, Sarah, these folks that have breakthrough cases, there are exceptions, but for the most part, there's significant protection against serious complications and death. And I think there was another question about getting a booster related to protecting the children in the home setting. And that is very reasonable to do, but it has to fit into the guidelines that have been released and we reviewed a bit. So breakthrough infection can occur, particularly with the waning immunity, and we know that boosts up. We're looking to the FDA to review a younger age group for starting boosters, that is 40, and that might even go down further. My prediction for the future is that we'll be faced with boosters in the future, and it may imply, as we do for influenza, when we choose each year which components should be included in the vaccine, what are the prevailing variants of COVID-19. In fact, it may be such that we're going to look at multiple variants, a multivariant vaccine for boosters in the future, but that's yet to come. And that's being studied as we speak. And in fact, there are current studies going on looking at vaccines that will include protection not only against COVID, but also influenza at the same time. Some of you may wonder, there is no interference in the immune response to influenza or COVID. So the timing of those vaccines is irrelevant. It does not interfere with the immune response. And in fact, they can be given simultaneously.
And I'll jump in for a minute and say we are currently giving flu shots on campus. Please come get one. You can look on our websites to see when they're being offered walk-in. You can also schedule them. And we are currently giving Pfizer boosters and we will be giving Moderna boosters. They may start actually sometime today. I think ODH authorized them.
Right.
And they will, otherwise they'll start next week, early, possibly Monday, and there'll be communication from the university about it.
Thank you. Believe it or not, we've actually gained our audience in the last 5 minutes because people have a question that they'd love Ben to respond to. The question that came in was, what type of accommodation can CWRU arrange for teaching faculty who are concerned with their risk and risk management going forward?
Thank you very much. I've got my tie, unfortunately, flapping. I am just juggling a few things here. The question the answer to that question is that we really do need, if you are in a situation where you do need to have an accommodation for your teaching, you do need to alert your chair as soon as possible. we have a tremendous amount of variety in our teaching across the university. And all of the schools are finding themselves in a slightly different situation. Given the uncertainties and the vagaries that surround COVID, and given a lot of the individual situations that are encountered at the institution, we recognize that there is variation, and we've talked with our deans to be open to the accommodations that you will need in order to do your teaching. So please talk to your chairs and notify your dean, because they will work with you to make the proper arrangements. Thank you.
I wonder whether I can indulge a few quick responses, because we are a little over. One came in for Bob around the current perspective on vaccines and booster vaccines for pregnant women.
That is strongly endorsed, and generally has been such that it's been recommended to give in the third trimester of pregnancy. In the month of August, for instance, there were 22,000 cases of COVID in pregnant women and about 22 deaths. So it is a risk for more severe disease and death. And I think that's important to recognize. So we do know for the mRNA vaccines that there's no transfer of the mRNA across the placenta, but women do develop antibody responses that are transferred to the newborn. And that is also an important phenomena. But in over 20,000 women that have been vaccinated, at least through studies, there have been no significant adverse events seen with the mRNA vaccines. The additional consideration in pregnancy would be blood clots that have been more associated with the DNA-based vaccine, that is AstraZeneca, which we do not have authorized in the United States, or J&J. So probably those would be avoided in the context of pregnancy. But the mRNA vaccines seem to be quite well tolerated. And it is an important time with relative immune deficiency that occurs in these women because of the pregnant state to strongly consider getting them vaccinated, as well as for the newborn subsequently.
Great, thank you. Lisa, I suspect that you'd like us to call it only because of time. There are a couple of other questions I wish we could get to, but unless you want us to be able to indulge, I better turn it back over to you.
So you're welcome. I will say that I know you all are very busy. And what we can do is I will let you all go and get back onto the very important things you're doing. And I'm happy to stay on and collect the questions, and we can maybe feed those to you all for answering, and we can get back to them with those answers. So I do have to say thank you very, very much to all of you for joining us today. This is a very important session. We are recording it, and we will put it on the Provost website. So for those who couldn't attend, they can take a look and get some information that was provided. Really appreciate it very much. So for our experts, you feel free to go. I will stay on for a few more minutes to collect additional questions that's needed, and we'll try to find those answers for you after over a couple of days. So thank you, everybody.